what could be a better synthesis than a presentation on mental health education interventions as a tool to address intergenerational trauma, kind of bringing it all together, right? And we're going to look at the ways that mental health education really can actively disrupt trauma transference, that working to identify educational strategies that are effective, and we're looking for the potential for healing. And some of the things that seem to be working are culturally sensitive interventions, family-based approaches, and we'll be talking more about that on Wednesday morning with Dr. Bunn, and community resilience programs. And here to do that, over under 2 minutes, I'm on it, okay, is Cristina De La Torre. And as I mentioned, she's all the way out here from San Diego, where she works with Survivors of Torture International, and with a real focus on data-driven program development and impact. And she works with the Health Education and Literacy Program, and she's in a great position to talk about how health education can impact intergenerational trauma. Cristina, please, welcome.
Hi, everyone, and good afternoon. If you are still here, thank you for sticking around. My name is Cristina De La Torre, and I'm with Survivors of Torture International in San Diego. I'm trying. Okay. Today I'll be presenting an integrative literature review examining how mental health education can function as a primary strategy to address intergenerational trauma in forcibly displaced populations. So as of 2024, over 120 million people are forcibly displaced worldwide. The trauma associated with displacement is not a single event. It is cumulative, it is multi-phase, and it is systemic. And what is critical and sometimes overlooked is that its effects do not end with an individual. Across generations, trauma can shape emotional regulation, family dynamics, and community functioning. And over time, that creates cycles of distress that extend beyond the original experience of displacement. In this way, trauma does not just occur, it persists. There is extensive literature documenting the psychological impacts of displacement. However, far less attention has been given to a critical question of how do we actively disrupt trauma transmission across generations? And more specifically, can mental health education function as a scalable disruption strategy? So this review examined 3 key areas. First, how trauma is transmitted across generations in displaced populations. Second, the biopsychosocial impacts at individual, family, and community levels. And third, whether and how mental health education functions as a disruption strategy. So this was an integrated review of literature published between 2020 and 2025. I really wanted to look at the most recent literature done on this topic. And searches were conducted in open access databases PubMed, DOAJ, and ERIC. 115 records were identified and 36 were included. The studies included diverse designs, systematic reviews, randomized trials, qualitative and longitudinal studies, and intervention protocols. The focus was on transmission mechanisms, impacts, and intervention relevance. So before getting into the findings, I'd like to ground us in the broader context of refugee trauma. In the literature, trauma in displaced populations is often described using something I'm sure we are all familiar with, the triple trauma paradigm. This includes pre-migration trauma, such as torture or persecution, trauma during the migration experience, like danger or family separation, and post-migration trauma, such as discrimination or legal insecurity. Very importantly, trauma does not end at resettlement, and that ongoing exposure is important when we think about transmission. In existing literature, trauma is conceptualized as simultaneously operating across multiple levels, biological, psychological, and sociocultural, and multiple systems, individual, family, and community. So what we are seeing is not just internal and individual stress affecting one person, but it is something that is embedded within relationships and within communities. And these levels do not function separately. They are all interacting with each other all the time. So when stress is sustained across these interconnected systems, without intervention, it can become reinforced over time. And that's what creates the conditions for trauma to become transmissible across generations. This framework helps us understand why transmission occurs, not just that it occurs in the first place. So how does trauma actually get transmitted between generations? Across the 36 studies, 3 primary pathways of transmission emerged. First, and most consistently, relational pathways. Second, socio-structural pathways, which were present in nearly all of the studies. And third, biological pathways, which were discussed in about half of them. And these pathways do not operate independently. They are interrelated and mutually reinforcing. Relational pathways include things such as caregiver trauma symptoms, disrupted attachment and emotional availability, communication patterns including silence and also narratives around trauma, and modeling of dysregulated stress responses. These mechanisms shape how children experience and interpret stress. These are the most consistently supported pathway across the literature. Socio-structural pathways include things such as racism, discrimination, and xenophobia, economic instability and legal precarity, and social isolation or loss of community networks. These conditions sustain chronic stress and also directly shape family environments. These are not just background conditions, as they actively contribute to transmission. In addition to these external conditions, several studies described internal physiological processes that contribute to trauma transmission as well. So biological pathways include chronic stress system activation, stress hormone dysregulation, and in some cases, discussion of epigenetic processes. But importantly, these biological processes are not happening in isolation. They're shaped by relational and structural conditions. We can see the impacts of trauma across the various intersecting domains. Biological impacts at the individual, family, and community levels, things such as somatic symptoms, household stress contagion, and a community-wide health burden. Psychological impacts at each level include things like elevated rates of mental health disorders, including PTSD, depression, and anxiety. Trauma-related family communication patterns, and collective grief at the community level. Social impacts include things such as isolation, inconsistent parenting practices, and avoidance of services. An important point to remember is that trauma does not affect every person in the same way. Impacts vary based on the individual, their developmental stage, and of course their environment. This means that both harm and recovery are shaped by context and available resources. And it suggests that interventions must also be flexible and multi-level. So this brings us to the key question of, if trauma is transmitted through relational, biological, and structural pathways, what kind of intervention can also operate across these domains? Ideally, it should be early, scalable, culturally adaptable, low intensity, and multisystemic. And mental health education meets these needs. I'd like to briefly define what I mean by mental health education in this context. I'm not just referring to information sharing, I'm referring to structured, culturally responsive approaches that help to improve understanding of trauma, build coping and regulation skills, reduce stigma, strengthen help seeking, and create opportunities for connection. Mental health education can also be delivered across developmental stages and community settings. One note that I'd like to make here is that not all of the included studies directly evaluated education-based interventions. However, many identified mechanisms that education is designed to target. I'd also like to clarify that the argument here is not that mental health education replaces therapy or clinical interventions, but that it functions as a mechanism-aligned preventative layer within broader systems of care. So we see several ways that transmission targeting plays out in education strategies. First, we have family-centered education. And this supports parenting, communication, and co-regulation. And this targets relational pathways by strengthening parental regulation, promoting trauma-informed parenting practices, and increasing family cohesion. We have mental health literacy. This can help reduce stigma and improve recognition of symptoms. This can help share information and encourage usage of available supports in the community. And this strategy helps to target relational and socio-structural pathways. We have skills-based regulation training, which helps to build coping, grounding, and somatic calming skills. It also helps support emotional regulation and provides practice opportunities. This helps to target biological and relational transmission pathways by decreasing somatic stress, managing physiological reactivity, and supporting individual and relational functioning. We also have community-based programming. These services help to build connection, belonging, and access, and this includes collaboration with community service sites such as schools. This helps to disrupt socio-structural transmission by building protective and supportive networks, restoring identity and belonging, and increasing social engagement. Each of these approaches aligns with specific mechanisms identified in the evidence base. Across studies, it is clear that effective disruption strategies target caregiver mental health, strengthen family systems, embed literacy in trusted community settings, pair education with referral pathways, and integrate structural supports. Because education alone is not enough without broader system-level support. This review contributes to existing evidence by repositioning mental health education as a mechanism-aligned preventative strategy, through demonstrating that intergenerational trauma operates through identifiable pathways, and showing that education can be intentionally designed to target those pathways. Mental health education is scalable and accessible in ways that clinical interventions alone are not. So, if we bring it all together, if trauma is transmitted through relationships, stress systems, and structural conditions, then intervention must operate across those same domains. Mental health education does this by strengthening functional relationships, supporting regulation, and increasing connection and access. And in doing so, can reduce the likelihood that trauma-related effects are transmitted across generations. At Survivors, this knowledge is reflected in programs like HEAL, our health education and literacy initiative. We offer services such as culturally responsive mental health literacy workshops, cohort-based psychosocial support and skill-building groups, bilingual and bicultural service delivery, and parent-focused education. We also integrate this work into schools and community partnerships. So I'd like to end with a few conclusions. Intergenerational trauma is not inevitable, but disrupting it requires interventions that match its complexity. Mental health education is a scalable, accessible, and strategically aligned part of how we begin to disrupt intergenerational trauma. Thank you for your time and attention. I'd be happy to answer any questions.
Thank you so much, Christina, for your presentation. I'm just curious, like the concept specifically intergenerational trauma, is that addressed in the scope of the research that you reviewed? Like, I guess my question is naive, like do these programs actually say, cover intergenerational trauma with the clients or their families to say, hey, we want you to learn about what this is, or is it specifically mental health education in a more, you know what I mean? I don't know if I'm making myself clear. Do you actually say, have you heard about intergenerational trauma? This might be affecting you in your parenting or your family dynamics. Or
Are you talking about strategies within the literature or at survivors?
both, I guess you could speak to that too. I know that where I work, we don't specifically have, I don't know that we name intergenerational trauma within the scope of the therapy services. Maybe it's addressed sort of like, you know, how are things with your family or something like that. But, you know, to learn, you know, the way that, say, I would look up intergenerational trauma and read about what the symptoms are and how it's transmitted. But how explicitly is that a component of these educational, yeah.
Okay, I see, I understand. I think currently it's not a targeted discussion that we necessarily name, but it is something that is brought up within the groups that we hold. So talking about how your parenting does affect your children and how different strategies, how can we teach and talk about different strategies that will help promote the well-being of your children. We don't explicitly say the word intergenerational trauma or utilize the term, but we definitely try to define it and talk about what it means and how unaddressed trauma can be transferred to children in that way. So how can parents take care of themselves, and how does addressing their trauma and improving their wellness actually help the functioning of the entire family?
Hi, everyone. This is Amy Camel. I just wanted to share a comment that came up. Christina, thank you. This is from Fatin Jaffer in Dearborn with Access. Your presentation was amazing. It was exceptionally insightful, particularly in how you clearly articulated the three distinct phases of torture: the initial experience of torture, the suffering endured during migration, and the post-torture phase. This was so very thoughtful and structured approach that demonstrated a deep understanding of complex cumulative nature of our clients' experiences. So, just wanted to share that.
Thank you so much for that kind comment.
I have one question. Do you guys, is it accessible to have the curriculum, or how do you disseminate it if, you know, organizations are interested in, you know, your workshops or presenting? How long usually these programs go for if you're doing a workshop or you're trying to do some sort of education? Is this talking about days, weeks, months? Just interested to know the implementational or the applicational part of this mental health education.
Yeah, sure. I'd be happy to talk about that. So we have several different types of workshops that we currently provide. We have a one-time mental health literacy workshop that has been developed by our team of bicultural, bilingual program specialists. And then we also have an MHPSS curriculum-based workshop series that's currently 6 sessions that usually takes from 2 to 3 months to cover. We meet on a a bi-weekly basis or whenever the client's schedule allows. And that's in a cohort base, so the same group will be meeting. And that curriculum is based off of an MHPSS curriculum developed by UNICEF. However, it has been culturally adapted by our program specialists. We currently work with the Afghan community a lot and also the Syrian community in San Diego. So it is culturally responsive to those two communities at the moment. But also I'd be happy to share with you if you'd like. You can contact me and I'd be happy to send you some resources. Okay. Thank you all so much.